Okay, welcome everybody to this afternoon's workshop on self-harm and assessment of suicide risk in adolescents. We welcome Dr. Isabel Paz, who is a child consultant and psychiatrist who has extensive experience working in CAMS, in inpatient child mental health facilities, and who currently works in children's psychological medicine at the Oxford Children's Hospital. So welcome, Dr. Isabel Paz. We look forward to hearing your presentation on self-harm and assessment of suicide risk in adolescents.
Hello, good afternoon, everyone. I hope you can all hear me okay. I'm sorry I can't put my camera on because I'm on a hospital computer that doesn't have a camera, so apologies for that. I was asked to talk about self-harm, and self-harm is such a broad subject that I wanted to a little bit in a way and also explain why teenagers are particularly susceptible to self-harming and why they behave the way they do, and how, as psychiatrists or mental health providers, we kind of assess that risk. I didn't want to bore you with millions of numbers and percentages and statistics and papers, because I think people just don't necessarily remember any of those things, and people can do more if they want to. I'm more than happy to give you some pointers if you want to do more reading about it. But I think the best thing I can do today is to kind of tell you a little bit about what I've learned by working with adolescents in the last 20 years, and what I think of my experience is good to share with you. Can we have the next slide, please? So the first thing I want to talk about is, as I said, it's a bit about the adolescent brain. And there's this amazing psychologist called Sarah Jane Blakemore, and I give you the reference at the end. And if you have time and you're interested in this, you can see one of her TED Talks, which are fantastic. But basically, we think about adolescence just about the teenage years, but actually in kind of neurobiological terms, adolescence is defined as the period of life that starts with the biological, hormonal and physical changes of puberty, and that ends at the age at which an individual attains a stable, independent role in society. And I like this definition because, you know, neurobiologically, you know, the brain is still in adolescence until you're well in your 20s. And I don't know how long it took you all to attain a stable, independent role in society, but it took me a very, very, very long time, well beyond the age of 18. So, and through all of that time, I think we need to remember that the adolescent is kind of becoming what they will be like as adults, and there are huge amount of changes that happen in the brain at that time. And I just wanted, next slide, please. I wanted to mention that, you know, adolescents in general have a really bad press, and they're generally, I think, quite misunderstood. And I found this study done by women in journalism, and they looked at how adolescence was represented in the general press, in the papers. And what they found was that more than half of the stories about teenage boys in newspapers were about crime, and the word most commonly used to describe them was jobs, followed by thugs, sick or feral. When there was good feedback about adolescence, and there describe in terms of model student or angel or perfect son was when these teenagers had sadly passed away in, violent or untimely death. And research found that for all coverage of teenage issues, the voices themselves were rarely heard in newspapers, and fewer than 1 in 10 articles about young people actually quoted the opinions of young people or their perspectives. Can we have the next slide, please? And I just want, this is just a bit of a joke, but it's true that we often have kind of really, I think, unrealistic expectations about teenagers and about how, because they look like adults, I think we expect them to behave like adults, and they're not adults in any way. So next slide, please. So just carrying on with brain development. So these days, because we have a lot more technology, we are able to look at adolescents' brains, and we've got things like MRIs and functional MRIs. So functional MRIs lit up bits of the brain where they're in use and allow us to explain behavior in biological terms. And what we know happens in adolescence is that there is a massive decline in the grey matter in the prefrontal cortex. So that's the front of your brain. And that is due to a kind of phenomena called synaptic pruning. So this is similar to, if you're into gardening, what you do in your garden with roses. So synaptic pruning is similar to pruning your roses. So when you're growing up and as a child, your brain is constantly developing pathways. And once those pathways are set, they determine the way we think and the way we behave later on in life. So during this adolescence period, what happened is that, like when you're pruning the roses, you're taking the kind of lateral, less useful branches, and you're leaving the ones that you find that are the stronger and the ones that are giving you more kind of successful flowers. So this is the same with the brain. In the brain, you're kind of getting rid of lots of accessory pathways in your brain and leaving those ones that are going to determine who you are. And the prefrontal cortex is the bit of the brain that is responsible for all of these things, which are the ability to take other people's perspectives, impulse control, emotional regulation, focusing and attention, complex planning, and ability to ignore external distractions. So the ability to inhibit impulsive behaviors does mature gradually during childhood and adolescence, but effective control is not achieved until you are an adult. Next slide, please. So when you are in the adolescence period, and what are people like? What are adolescents like? So adolescents tend to be very anxious. So anxiety is when someone kind of worries about the future. And they don't maybe worry quite so much about present dangers, but they worry about the future. So anxiety, that distinguishes anxiety and fear. So adolescents might not have a lot of fear, but they certainly have a huge amount of anxiety. Okay, they have a lot of mood swings, which are, ability to regulate their emotions. And this is caused by both hormonal changes, but also by changes in their brain development. They suffer from a lot of confusion and indecision. You have to remember that adolescents are experiencing multiple changes to their bodies, their environment, what people expect from them, and often they find it really quite hard to keep up with what other people are expecting of them. Can you put the next one up, please? So they also suffer from lethargy because they often don't prioritize eating or resting, you know. And a lot of parents say to me that their adolescents are often either on or off, you know, they're either kind of sleeping until lunchtime or they're out and about and they don't stop, you know, and they don't seem to have a lot of in between. They tend to be argumentative because they're at a stage of life when they want to make decisions for themselves and they want to do things their way, while adults, and that includes you guys, the teachers and parents, want them to behave like mature individuals. So that creates conflict and arguments. They're also angry and irritable. And that's because, you know, there is a lot of thwarting of desires, what they want to do and what they're allowed to do are two different things. They constantly feel interrupted in what they want to do. They often feel that people are constantly finding fault on them and teasing them or lecturing them or making unfavorable comparisons with other children. And that over time leads to anger. And I just, again, we try to put ourselves in an adolescence. I think what I'm trying to say is that we often forget that adolescence is a bit like childbirth, in that, you know, once you go through it, you sort of quickly forget about it, you know, in that we all, I think we remember being adolescents, but we don't remember all of the kind of difficulties that come with being an adolescent. And once you get to adulthood, you quickly forget all of those things. And the last thing I wanted to mention is that adolescents also tend to experiment, and part of experimenting is, you know, to learn. So you need to try things out and see what works and doesn't work for you. But in adolescence, that is often paired with risk-taking and greatly influenced by their peer group. And again, if we think back to when we were adolescents, I know I did more than one or two stupid things when I was a teenager because I was with my friends and that's what we were all doing. And I think, you know, we all go through that period and that kind of process, and it is part of your learning. But as you move on, you know, you find it kind of that you almost forget about that. Next slide, please. So this is just another kind of little joke. So Jimmy, why are you acting up in class? Because my prefrontal cortex, the part of my brain that controls decision making, develops much later in late adolescence. Therefore, it's difficult for me to control my risk-taking actions. And yeah, anyway, next slide, please. So I want to now talk a little bit about kind of self-harm and suicide, because that's what you asked me to talk about. So just a few kind of numbers, which are, you know, sobering numbers, because this is a really difficult topic to talk about. But around 5,000 people die every year from suicide in England only. And on average, that's about one person every 2 hours. And this is not just children, this is people.
You know, I'm not video.
Around 700 of them would be under the age of 20. And therefore, suicide accounts for about 20% of all deaths in young people between the ages of 15 and 24. It is the commonest cause of death in men under the age of 35. And around 25,000, young people present to A&E with deliberate self-harm each year in the UK. And we actually don't know what the real rates of suicide are, because they're probably about 50% higher than the values that I just told you. And this is because there is still a huge, huge stigma around the topic of suicide. And coroners and families still prefer that suicide is recorded as misadventure in coroner's reports. So there's been several studies that have been done kind of looking retrospectively back at coroner's reports, where kind of a huge number of deaths in young people have been recorded as misadventure rather than suicide, when clearly that's what the cause was. Okay, can I have the next slide? So the next slide is about, this is Professor Keith Horton is one of the professors at Oxford University, and he has been researching self-harm and suicide, both in young people but also in adults for many, many years. And he proposed this iceberg model of self-harm and suicide in young people. So suicide would be the absolute tip of this iceberg. So the self-harm that presents to clinical services, that would be INE or CAMS or GPs, is the visible bit of the iceberg. And then there is a huge, huge amount of self-harm that happens in the community that doesn't present to anybody, any professionals, and that we do not know about. And in a way, you know, that is the bit that worries me the most, because the one that presents to services, at least we can do something about, but is these huge amount of people, that young people that are down there that we know nothing about, who are incredibly unhappy and who are self-harming quietly in their bedrooms without telling anyone. I think, again, just for to give you a bit of context, we know that about 10% of children do have thoughts of suicide at some point during adolescence, and about 20% of children would have thoughts of self-harm at some point. Okay, next slide, please. So what is the connection between mental illness and suicide? So we know that suicide is more likely to happen in people that have mood disorders, in people with schizophrenia, in people with bipolar disorders, and in people with addictions. But we also know that a significant proportion of those who commit suicide don't actually have a diagnosable mental illness. And those are also part of that huge amount of people that services know absolutely nothing about. Okay, and where suicide often comes as a bit of a shock to the system around them. Okay, can we have the next slide, please? So this is just a slide about extreme stress and despair by age. And I'm putting this slide up because I think we are but used to teenagers being unhappy, but actually there is also a huge proportion of young children in primary school who also express extreme despair and stress. And I think, you know, culturally, we want to believe that young children are very happy and, you know, that they don't worry about things. But actually, in reality, you know, 7% of children, 12 or younger, are under extreme stress, and 3% will express extreme despair when asked about it. Next slide, please. So I said I would kind of give you just one study about deliberate self-harm and suicide. And this was a study done looking at records in GP surgeries. And they looked at children and adolescents aged 10 to 19 between 2011 and 2014. And it was a huge study. And what the references at the end if you want to look into it. But basically what they found was that the overall rates across the study period was 37.4 per 10,000 in girls and 12.3 per 10,000 in boys self-harm. Okay, so among girls 13 to 16, the rate increased by 68% between 2011 and 2014, raising from 45.9 to 77 per 10,000 of population. So, you know, if your impression is that rates of self-harm are going up, that is absolutely right. They are, and we are seeing it going up year upon year upon year. So the highest rates in this study were in the more deprived areas, which is not surprising, and girls were the only group where the rate of self-harm sharply increased across the study period. And in many cases, there was involvement of drugs and alcohol. And as I said, there was a higher rate in more deprived areas. Can we have the next slide, please? So they then looked at what happened to those children who had self-harm in the following 12 months. And what they found was that in boys and girls, roughly 1 in 5 self-harmed again, although this was slightly more common in girls. They also found that only about 44% had a documented referral to mental health services, so not even half of those children had actually been referred to services. And in 12% of cases, this had been done even before the self-harm episode had happened. And again, we are all very aware of waiting lists for mental health services in general. So about 1 in 5 girls were prescribed antidepressants, and those in the most deprived areas were less likely to be referred or to be prescribed medication. And I'm mentioning this, I think this is a very important point, because I think that a lot of the effort goes into children who come from less deprived, more able backgrounds. And I think the children who come from more deprived backgrounds are often forgotten, because people feel, well, no wonder they're self-harming because there is kind of abuse in the family or alcohol or whatever, and actually they're not given the services in the same way. And I think that is a real problem that we have, because they don't access the help that they need. And in the UK, just finally, between 2010 and 2015, suicide rates amongst 15 to 19-year-olds rose from 3.2 to 5.4 per 100,000. So a massive increase in the last few years. Can we have the next slide, please? So again, some other facts is that 10% of people who make a suicide attempt will later die by suicide, but 90% don't, okay? 1% of all suicides occur in NHS psychiatric hospitals. And again, there is this fantasy that if people go into hospital, they can be protected from themselves. And I think, you know, hospitals and psychiatric hospitals try their very best to keep their patients safe. But even if every mental health treatment team magically protected every person they saw for a month, about 70% of suicides will still occur. And that comes back to my point before, that a lot of people who self-harm or commit suicide are not necessarily known to mental health services. And sometimes the self-harm and the suicide comes as a bit of a shock to those around them. And again, just to say that in the last 20 years, rates have fallen in older people in terms of suicide, but have risen in the young. And the highest rates are now in men age between 30 and 39 years old. Okay, next slide. So why do people hurt themselves, or why do people try and commit suicide if that's what they're doing? And I'm saying that because not everybody that hurt themselves and harm themselves actually want to kill themselves. A lot of them want to release tension and deal with emotions that they're not able to express or they're not able to share with others. So what is the motivation really? Well, for some people is because they feel a lot of school pressure or shifting in social pressures, family losses and changes. For some people it's fatalistic because they feel hopeless about the future and they feel that they had repeated disappointments that they can't get over. For some people it's about isolation, so because they live in isolated communities, because they're transgender or bisexual or gay, or because they're victims of trauma. For some people it's about altruism, so it's about protecting parents or friends, and because they have remorse over perceived infractions. So this is the typical where the young person feels that people would be better off without them because they've worried them or they let them down. Can we have the next? And I wanted to mention this because there is a certain number of teenagers that present who actually they don't know why they do it or why they feel the way they do, and they're not necessarily any triggers about this, and with the best will in the world, we try and assess risk in teenagers, but often they don't know themselves, and sometimes it's due to having a very dark moment and being quite impulsive and regretting it immediately after. Next slide, please. So when we are assessing suicide risk, we rely very much on collateral information, and that's why we often will be calling you guys at school to see how this child is doing and how they're behaving at school and how they're behaving with friends. You need to have confidence and you need to have experience and expertise in this area, but you also need to have a lot of common sense, and you need to kind of remember that these feelings are changeable and that what you're assessing is how that child presents to you at that moment in time, but that a few hours later they might kind of feel completely different from what they do now. And that is a difficulty because often we can not predict that, and we can just predict by previous behaviors of what they've done before, our knowledge of them, their parents' knowledge of them, the school knowledge of them, and we create a picture that kind of allows us to make a educated guess about what the risk is in going forward. Can we have the next slide, please? So there are factors that influence kind of your risk of self-harming and potentially committing suicide. And some of those factors are changeable and some of the factors are not changeable. So in terms of the ones that are not changeable, so are things like age, sex, whether there is a family history of suicides, whether there is a family history of mental disorder, whether there are prior attempts of suicide, whether there's a historical diagnosis of a psychiatric disorder, whether they're using drugs or alcohol, or whether there is a history of loss and trauma. But there is other factors that are changeable and that we can kind of influence and help them with. So, and these are things like access to lethality. So, you know, when I'm making a risk management plan with young people and their parents, we often ask them to lock any medication and sharps away. So if the young person finds themselves in a moment of darkness when they have that impulsive need to harm themselves, they don't have immediate access to those means. If they have an untreated mental health disorder, obviously we would find a way of treating that disorder. So if they're depressed or they're anxious or they've got a psychotic illness, if that mental disorder has been present for a while but actually is worsening because their medication is no longer working or because some of the support networks have disappeared, if they're dealing with recent loss or a life crisis, we can help them to understand and kind of problem solve, or we can give them kind of bereavement counseling, lack of social or formal support. So some children who live in problematic backgrounds might need kind of social care involved or other kind of statutory and non-statutory agencies to help them and support them. If they're not responding to medication, if a caregiver or family member is unable to provide the care that they need, or if they're suffering from addictions, all of those things we can do something about and help them with. Can we have the next one, please? So what do we do? So what I wanted to say is that when I'm doing an assessment, you know, I will be looking to see whether the risk, the suicide risk that they're presenting with, is it a chronic risk or is it an acute risk? Okay, some children have got self-harm or have been self-harming and have got suicidal thoughts that go back a very, very long time. And for whatever reason, they have not been able to learn ways of dealing with their emotions and managing their emotions. And therefore, self-harm and suicide attempts become their only coping mechanism. And these children have less kind of changeable factors, okay? And for these children, what they need is a CAMS intervention. So they need to learn those skills to manage their emotions, and they need to develop strengths within themselves and other more adaptive ways of managing their feelings. But these children don't do well in hospital because relearning how to deal with managing your own emotions in a completely different way takes a very, very long time. And hospitals, if you put a lot of children with emotional regulation difficulties in the same place, and you know, what they end up doing is competing with each other, outdoing each other, and getting themselves, the peer pressure becomes even more difficult to manage and more toxic. And these children tend to do really, really badly in hospital. And you know, they're much better managed in the community if at all possible. Can we go to the next one, please? However, if this suicide risk is acute, it means that we have identified a lot of changeable risk factors. So for whatever reason, that young person's coping mechanisms are not adequate to cope with whatever it is they're going through at that moment in time. But with the right help and support, we can sort of get them better again. So this makes a strong case for CAMS treatment if able to engage in treatment and safety planning. And the aim is to address and change all those changeable risk factors. But for these children, also hospitalization might be needed, because if the risk is imminent and they're not able to safety plan, then a short period in hospital where those risk factors can be addressed and they can again kind of find new ways of dealing with the emotions that they're not coping with at the moment would be really helpful. So can I have the next, please? And then the third scenario is where you have somebody who has a long history of deliberate self-harm and poor emotional regulation, but that somebody suddenly is faced with an acute situation that increases their risk. And for those, again, sometimes hospitalization, going to an inpatient psychiatric unit where the acute risk factors can be managed would be a good thing to do. But remember that, again, I wouldn't encourage these people with these children with chronic issues to stay in hospital for long periods of time, because they are at risk of becoming institutionalized and actually becoming get worse rather than getting better. So next slide, please. So I put this slide in because I think often, you know, I feel like it's really difficult for families when they have a teenager who is in crisis, a teenager who is hurting themselves, who is having a really, really tough time. And I often have to kind of spend a lot of time with these families and think about what is in this child's best interest. And often families are at the end of their tether and they feel that, you know, why are you not taking them into hospital? Why are you not kind of putting them in hospital and giving us a break and giving them a break? And the reasons why hospitals should not be the first kind of thing that we think about. I mean, I often tell families, you know, for me, it's a lot easier in a way to admit somebody to hospital, because when they're in hospital, you know, there's somebody else's responsibility, and actually, you know, I don't have to worry quite so much about it. But when I am making those kind of decisions, what I'm thinking is this in the child's best interest? And these are some of the reasons why sometimes admitting to hospital is just not in the child's best interest. So, for example, it's so scary to go into an inpatient psychiatric unit. You know, you're subjected to procedures and tests, and you have to meet new people, you're separated from your family, you're worried about your health, you have to adapt to a completely new environment with new rules and adapt to a whole load of young people as well who have their own difficulties and who are also in crisis. I think children who are admitted to inpatient psychiatric units often feel very isolated because they're not able to see their friends, and the families visiting times are restricted. And that has even worse, of course, because of the COVID pandemic, where, you know, visiting is extremely restricted to inpatient psychiatric units like it is to any other hospital. When they are in hospital, there is a decrease on kind of the little activities that still make them feel good about themselves, like playing sports or engaging with friends and doing things that can bring fun to their lives. It's a major life change. and potentially, is something that would have a massive impact in their development. Obviously, we need to think also about parental upset and stress and separation. And as I mentioned before, we always worry about contagion and what happens when kind of lots of teenagers are put in a small environment where they're all struggling with similar kind of emotional regulation difficulties. And they tend to often either kind of encourage each other or compete with each other, and it might have a massive negative impact on the way they behave and on their mental state. Next. So just to conclude, and I want to leave a few minutes to some questions, but suicide is a multifactorial problem and requires a multifactorial solution. Risk assessment tools have very, very poor evidence. People have been looking for this magic kind of questionnaire that we can give children and will tell us exactly, who we should be worrying about and who we shouldn't. And the truth is that none of these tools actually have any validity when it comes to kind of predicting suicide. Evidence to support management of suicide risk has not been robust, and what it boils down to is that taking a good history and is the kind of mental health practitioner or the psychologist or the psychiatrist, whatever it is their clinical nose that is the most accurate risk assessment tool. And if you are dealing with a child who is having suicidal thoughts and who is self-harming, I think my advice is to be curious, to be compassionate, and to be honest, and above all, also to be humorous if you can, because sometimes just being able to have a bit of a joke and a laugh, even if it doesn't mean that you're not taking them seriously. It means that you're able to change the mood a little bit and kind of show them a different side of life. I often do a lot of kind of self-deprecating jokes or make jokes about myself when I'm interviewing children who are self-harming, because I think that kind of lets them know that you're not judging them and you're not there to kind of tell them off or to make, as I said, to pass judgment. Is more about kind of you're on their side, you're human too, and you're just there to try and understand where they're coming from. Next question. So this is just a joke, but and next one, just for references. So as I said at the beginning, Professor Sarah Jane Blakemore has written an amazing book called The Secret Life of the Teenage Brain, which explains why, as I said at the beginning, teenagers behave the way they do. And if you don't fancy a thick book, she has an amazing TED Talk as well that you can access on YouTube. And that is the reference for the paper that I mentioned earlier. Okay, and that is it. So I hope I've been able to teach you something, or that you have found my insights helpful. And if anybody has any questions, I'm more than happy to answer them.
Thank you, Isabel. There was one question in the chat bar, and that's from Sarah, and she asks, in the statistics, are children diagnosed with anorexia nervosa who may die, are these included in the overall suicide figures as well?
No. So anorexia is a completely separate kind of catalog, not completely separate, because I mean obviously there is overlap as well. So some children with eating disorders also self-harm as well. Okay, but the mortality rate for eating disorders again is about 10%, but they often die from complications, so physical complications of the not eating, so physical complications of starvation. Okay, and they don't necessarily want to kill themselves, but the way they're thinking, or that the illness makes them think, is that they rather die than put on weight, but is different from self-harm, and is not with a view of managing their emotions. So it's a different kind of emotion, if that makes sense. Has that answered the question? So in the figures that I was given, the mortality of anorexia nervosa is not included. Thank you. Any other questions?
So, yes, Sarah said that has answered her question. I'm not sure if you can see the chat bar.
Yes, I can now.
Oh, good. Okay. Any other questions that anyone wants to ask? Okay, thank you, Dr. Paz, for your presentation today. It's a topic that I'm sure that has enabled us to have a greater understanding of the suicide assessment process. And for us as teachers, parents, pastoral workers, whatever we are, in what capacity that we've joined today, it's sometimes really difficult for us to accept sometimes when a child is not accepted into hospital with self-harm or suicidal ideation. So it's really useful for us to know how and why it is not always in the child's best interest. And I think you covered that very well. So thank you.
Okay.
It's certainly something that comes up quite a lot with my colleagues that call in and say, you know, oh, they're being discharged already. And so I think you made it quite clear that sometimes it's actually detrimental to their well-being being into the hospital. So yeah, thank you very much. It was really interesting. Any more questions or any comments anyone wants to make? Okay, so I think you can read the comments coming through. I'm just going to say to my colleagues for the medical needs in schools that our next confirmed workshop is, we're going to have a break now for December. There's only a week of term left, well, a week and a bit. So the next workshop is going to be on anxiety, and that's going to be on Tuesday, the 12th of January, 4 o'clock till 5 o'clock. And the presenter will be Dr. Helen Griffiths, the clinical psychologist based at the Oxford Children's Hospital that we have had pleasure of her company before, and I'm sure you know her well, Dr. Paz, don't you?
Yes, I do. We work together very closely.
Okay, so we look forward to hosting you and seeing you again on the 12th of January. Many thanks again, Isabel.
Thank you very much. Bye.
Bye-bye.